So today, with the help of case examples, I will show you how CT-guided biopsy can help us in day-to-day practice. First of all, this was a 75-year-old female who presented with generalized weakness under evaluation because of the opacity which was visible on the chest X-ray. She was advised a PET CT. The initial thought was that this was a neoplastic lesion, and the PET CT also showed a relatively peripheral lesion having certain areas of breakdown with good amount of enhancement, and which was intensely PET avid. Initial thought was that this is a malignant lesion even on the PET CT. Based on the advice of the clinical team, she first underwent bronchoscopic biopsy, but the histopathology was inconclusive. It showed mostly benign tissue, not even granulomas, and the gene expert was also negative for tuberculosis. After certain days of empirical therapy, she was then referred to me for a CT-guided biopsy. I took her for the biopsy. So how we perform the biopsy is we localize the lesion on CT, give local anesthesia, and then park our coaxial biopsy needle into the lesion. So that is what we are doing here. You can see the needle coming in from the anterior chest wall and landing bang on into the lesion. This is the lesion. So the biopsy showed tissue having Langerhans and multinucleate giant cells. Even the ZN stain which was performed on the biopsy slides, it showed acid-fast bacilli. So it was clearly necrotizing inflammation of tubercular etiology. The gene expert was also positive. So the diagnosis of TB here was clear cut, and she has been put on ATT for the pulmonary tuberculosis. The family, they were totally relieved because everybody was fearing cancer. Another 65-year-old gentleman who presented with vague chest pain, no history of fever, no weight loss. He had a large lesion in the left lingula, and there were multiple nodules with ground glass densities in rest of both lungs. Again, non-specific appearance, whether it is infective or it is neoplastic. Nobody was pretty sure. Again, he underwent a bronchoscopic biopsy with bronchoalveolar lavage. It was again inconclusive. So we went in, did the CT-guided biopsy. He had small amount of pneumothorax, but was managed immediately with a uh, pectoral catheter, which was placed for a short while, and he recovered. After 2 hours of observation, he was comfortably sent home. And the biopsy, it came out to be non-small cell carcinoma favoring adenocarcinoma. So similar imaging appearances, similar age groups. Without a biopsy, we would not have been able to confirm our diagnosis, and so our treatment would have been totally without any evidence. So it is the CT-guided biopsy which bailed us out in both these cases. So overall, the principle is that for focal lung lesions, CT-guided biopsy can effectively give us answers where bronchoscopic biopsy is inconclusive. A good CT-guided lung biopsy will give you good amount of tissue, so that even if the uh, uh, a malignant lesion is diagnosed, you can perform the detailed immunohistochemistry and the next generation sequencing, which is now the standard of becoming the standard of care for management of carcinoma lung. So for all the central lesions, you can perform bronchoscopic biopsy, but for peripheral lesions, the results of bronchoscopic biopsies are much inferior compared to CT-guided biopsy. all peripheral lesions, your first choice should be CT guided biopsy. Obviously, you have to take the other factors into consideration, like what is the nature of the background morphology of the lung. If the background lung is uh, emphysematoous, there are lots of bullae, there is lot of fibrosis, then the patient is more likely to have complications like pneumothorax, and you have to prepare the patient, prepare yourself so that you are able to effectively handle such complications. In good hands, a CT guided lung biopsy otherwise is generally a safe procedure. Thank you.